of time. That was published in 2017. After this review in pediatrics that was published in 2016, that basically took a look at over 500 pediatric specific trials that were registered with the federal government. And what they found was that over half of those trials never actually resulted in published data. That's because about 20% of them were never completed, and about a third were never published. And the authors talk a little bit about why that may have been the case. And a few things that they talked about were they just didn't have enough patients for enrollment. In pediatrics, patients are pretty diverse and don't always meet inclusion criteria. And although the FDA has incentivized drug companies to include pediatric patients in their drug trials by giving them extended patents, there's really no incentive to publish that data if it's not favorable. So where does that leave us? Where does that leave all these assistant professors out here trying to start our careers while trying to, also learn how to be an attending and manage a busy clinical practice? So the good news is there are lots of data gold mines out there. This is just an example of all of the national quality improvement registries that we are involved with at Seattle Children's Hospital, kind of ranging from the depth of looking at, pediatric intensive care outcomes, surgical outcomes, and sort of quality improvement projects for single ventricle specific populations. And I really want to focus in on the fact that these are data gold mines. We invest a lot of time and personnel in collecting and recording this data, and I think we can really do some powerful work to use these data in real time to impact our patients. So as an example, I want to talk a little bit about one of these quality improvement collaboratives, which is the National Pediatric Cardiology Quality Improvement Collaborative. It's kind of a mouthful. People just call it the NPC-QIC for short. And essentially, it's a quality improvement collaborative across the country. It includes over 60 pediatric cardiology surgical sites. And their goal is to really use collaboration and data to improve outcomes for patients with single ventricle congenital heart disease. So in layman's terms, that's children who are born with essentially half of a heart, and usually it's the left side of the heart that's not fully developed. And essentially, these kids basically have to undergo a stage of 3 palliation or of surgical palliations. And the first one is called the stage 1 palliation. It usually occurs at the first few days of life. And what's really interesting is that, these children usually get discharged around a few weeks of life, and then they return for the second stage around 2 to 4 months of age. And what we found is that these children, despite really, really impressive efforts by the NPC, QIC, and other groups to surveil them daily, sometimes multiple times a day, these children face, really high rates of morbidity and mortality. So around the stage 1 palliation itself, there's still about a 10 to 15% rate of perioperative mortality. These kids often stay in the ICU and in the hospital for many weeks. And what's really terrifying as a physician is even in the subgroup of patients who are discharged home after the stage 1 palliation and before the second stage, or the so-called interstage, there's a pretty significant rate of mortality. So it's 2 to 15% rate of mortality in the so-called interstage period. And again, these are kids who were thought to be well enough to be discharged home. And what's more terrifying is that these kids often deteriorate quite suddenly. So I mentioned they get check-ins, oftentimes daily by staff at the surgical site, and they still often have events without any warning. And when we've looked at these patients over time and kind of focused in on the subgroup of patients who had post-mortem autopsies, we still don't know why these kids have sudden events in about half of patients. And so, it's not a great place to be as a physician trying to decide whether or not to discharge a patient home. So as a fellow, I started working with the NPC QIC to sort of address this problem. What we decided was, we have this great database through the NPC QIC of thousands of patients across the country. And how do we use that data to help us make decisions? So we wanted to create really what would be an objective and quantitative risk score that we could use prior to discharging these kids home following the stage 1 palliation to really help clinicians risk stratify them. What we wanted to see was what was the primary composite event rate of either interstage death or being referred for a heart transplant. And again, this is after discharge from stage 1 palliation. So the phase 1 database that we used basically included patients between 2008 to 2015. It included over 2,000 patients. It's a lot of patients in pediatrics, especially when you're talking about single ventricle heart disease, which is overall quite rare, across 60 surgical centers across the United States. And in order to make the most of this database, we did something interesting using the help of our statistician friends, which was to separate these patients into a learning cohort. So we randomly selected 75% of these patients to really derive our risk score. And then we validated that score internally on the remaining 25% of patients. And we had made a plan early on to sort of validate the score externally at some point, and we just completed that in the NPC QIC phase 2 database, which I'll share here today. So without going into too many details, I just want to point out again, we had a learning cohort of over 1,000 patients, pretty broad array that represents typical single ventricle patients really well. What we found again was in these patients who were all discharged home following the stage 1 palliation, there was a 9% rate of our composite event rate, which again was a combination of interstage mortality or transplant, so almost 10% of kids. And in order to understand, some of the risk factors that may have been associated with the primary outcome in these patients, we did a few things. So one was to do a classification and regression tree analysis or CART analysis. And essentially that's a statistical technique that helps identify a single variable that's associated with the greatest skew in data. And as you can see, again, 9% overall rate of the primary outcome in our patient group. And the biggest variable that was associated with the primary outcome was patients who, when we looked at their echocardiogram or heart ultrasound before discharge, they had moderate or more tricuspid regurgitation, and they were discharged home with supplemental oxygen. So you can see 1 in every 2 of these patients met the primary outcome. So that's pretty powerful. So we then took that variable and we did a univariate analysis, and we included all variables with a p-value less than 0.2 as candidate predictors. So again, looking at CART analysis, kind of factors related to their surgery, hospitalization factors, patient characteristics, and discharge factors. And we use that to create a multivariable model, and we use that to derive what we call the NEONATE score, using essentially the first letter from each of the variables that were powerful. And I really want to draw your attention to 2 of the variables here. So there was an association between the primary event and patients who were discharged home on opiates and patients who were not discharged home on digoxin. And some of these other ones were a little bit more, difficult to control, like what type of surgery did they undergo? Did they require ECMO post-op? And what did their echo look like after surgery? And I want to hone in on this because these, were potentially modifiable factors that we really talked about every time we presented this at national conferences and ultimately in our manuscript. So that's the NEONATE score. The other thing we did was to separate patients into low and high risk subgroups based on a score differentiator of 17 points. And what we found was that patients who, again, at the time of discharge had a NEONATE score of 17 points or less using these variables, they had a significantly lower risk of interstage mortality or transplant compared to patients who did not. And again, we're talking about, an event rate of somewhere around 5% compared to 18%. So, over 3 times higher in patients who had a score greater than 17. So let's talk a little bit about the external validation that we recently completed in the phase 2 database. So over 1,000 patients, it was a more modern cohort, included patients from 2016 to 2020. Baseline characteristics were pretty similar between the 2 groups. You can take my word for it. But I really wanted to focus in on a couple of things. So one is that the event rate decreased in just 5 years from 9% to 6%. So overall, 4% mortality, close to 2% of patients requiring a transplant. So it's a 33% decrease in about 5 years. And when we looked at, again, validating the score in the phase 2 cohort, we found that our results were fairly similar. If you had a score less than or equal to 17 points using the NEONATE score, your rate of interstage mortality or transplant was about 5%. So lower than that if you had a score greater than 17, where it was 3 times higher at about 15%. And our score performed pretty well with over 90% accuracy and about 90% specificity as well. So that was exciting. And when we looked at how your neonate score related to your rate of interstage mortality or transplant here on the y-axis, you can see that there's almost an exponential increase in the rate of interstage mortality or transplant as your neonate score increases. So that was pretty exciting. But I was really excited by this. So one is that, a lot of these really powerful risk factors that we identified with the neonate score still remain independently associated with interstage mortality or transplant in this modern cohort. But what was really important was that, perhaps because of, sharing our data early with the NPC QIC, really being vocal about focusing on things that we could control, that in the interval, we saw a significant decrease in the number of patients who had these modifiable risk factors. So in the phase 2 cohort compared to the phase 1 cohort, more patients overall were discharged on digoxin, which again was associated with improved survival in interstage patients, and fewer patients were discharged with opiates, so much so that really there was no difference between the groups overall when looking in the phase 2 cohort. So that was really exciting. And again, we're talking about using multinational or multi-center national databases to really make differences in real time as we learn things. And that's also reflected in the fact that when you're looking again at patients only who are discharged home following the stage 1 palliation, that the overall median score decreased significantly from 17 points to 9 points. And this is, it's a prospective, but it's a database registry, so we can't really make a lot of claims about why that may have been the case. But we're hopeful that by focusing in on identifying patients early, that maybe we helped, move the overall mortality rate down from 9% to 6%, and maybe helped, clinicians focus on keeping high risk patients either in the hospital or surveilling them more closely so that they had fewer events in just 5 years since the publication of our initial trial. So that was exciting. It also gives us some really important questions to address, again, data-based moving forward. And again, it's, should we continue to move the needle forward by discharging all patients onto digoxin? What should we do with these patients who have that really high risk variable of having moderate or more tricuspid regurgitation and needing oxygen? Should they stay inpatient to tell the Glen? Should we be more aggressive about intervening on their valves? Not a simple question. And when you're talking about, 5-day-old infants with really friable tricuspid valves, but really important ways to focus in on addressing research. And one of the things that, Dr. Jones has been doing with the UW here and at Seattle Children's is, using adult technology such as the MitraClip, which was really designed for adult patients not stable enough to undergo surgical mitral valve repair, and using that in single ventricle patients who are big enough. And you can see that this is an echo of a lot of blue going backwards where it's not supposed to go, indicating a lot of tricuspid regurgitation. And just after 2 clips, they really get a nice result. And so people are working nationally on figuring out ways to do this more efficiently for children. So we have a long way to go, but lots of promising work. So I just wanted to shift gears a little bit to talk about another major powerhouse in the pediatric world, talking about quality improvement, and that's the ACTION Network, which stands for Advanced Cardiac Therapies Improving Outcomes Network. And really, I want to talk about Dr. Angie Lortz, who is an attending physician at Cincinnati Children's, who is a heart failure attending, focusing in on VADs, which are ventricular assist device in the pediatric population. How do I get rid of this? There we go. And she's really changed the game in the pediatric world and thinking about how to redefine academic success and how to promote better outcomes for our patients. When you talk to her about kind of what motivated her, she talks a lot about this book called Give and Take by Adam Grant, which is a great read that I'd recommend. And essentially, he talks about how there are givers and takers, mostly in the business world. But essentially, what's been found in national studies is that some of the most successful people out there are those who learn to stop caring about individual success and who really elevate those around them. And those people are incredibly successful because they create these really strong networks of support, and their individual ability to make change gets amplified by being able to use their strengths to help other people. It's a really powerful way that sometimes, goes against the grain of the standard way of thinking about what it means to be successful in our society, but especially in the world of academic medical research. Um, and this is really important, especially when we're thinking about pediatric patients with heart failure, who are a really diverse group of patients and who are really sick. And you can see that we started doing pediatric heart transplants in the early 80s. There's been a huge increase over time, but in the last 10 years, that number's really leveled off because there are only so many pediatric hearts available. But the number of sick kids with heart failure is just growing over time. And we can see that when we look at kind of children who are listed for transplant in the last 20 years, and about half of them, especially kids with dilated cardiomyopathy, are requiring some sort of mechanical support, whether that's ECMO or VAD, to get them to a heart transplant. So it's a huge number of patients. And we really, need multi-center collaboration to figure out how to get them there safely. So the Action Network's done some really great work. So this is actually something that's been developed for patient education by the Action Network. And it looks at the Berlin heart, which is one of the major pumps that we use for children with severe refractory heart failure who need help with a mechanical pump to get to a heart transplant safely. And essentially, you can see here, it's outside the body. It's not the most elegant pump, but it works. And you can see that there's, an air membrane that's moving back and forth to pump blood to the body. There's a lot of external tubing. A lot of it's plastic. It sometimes changes in size. And anybody who remembers Virchow's triad knows that that's not a great setup, and it leads to a high probability of thrombus formation. And especially when you're using this as a left ventricular assist device, if there's a thrombus here, it can go anywhere in the body, and especially the brain, which is what we're really worried about. And in fact, we saw that quite often in pediatric patients. So here's an example of a clot in the outflow cannula of the Berlin LVAD, and it resulted in a massive stroke in a pediatric patient. That's often what we saw even as early as 5 years ago, was that these kids were really sick and they didn't really have a lot of great options. But while waiting for a heart transplant using this Berlin pump, they had about a 30% rate of strokes. And oftentimes those strokes, when you think about big clot in a small baby brain vessel, led to massive injury and sometimes death. That's depressing. But the cool thing is that, actually when I was a fellow, one of my attendings sort of just got fed up by seeing these bad outcomes, and she hit the literature to figure out ways to make it better. And what she found was that, especially in infants, there's not enough AT3, and AT3 is usually what helps make heparin as an anticoagulation effective. So you can see here that, when you're looking at baseline antithrombin or AT3 in pediatric patients, it doesn't really correlate well with anti-10A or PTTs, which is what we use to titrate heparin activity. So the thought was, we're using a medication for anticoagulation that doesn't really work well in the patient substrate of infants we're targeting. So what can we do better? So she hit the literature and came up with this medication called bivalirudin, which is essentially a direct thrombin inhibitor. It works really similarly to a lot of the DOACs, like apixaban, that the adults use. So you're sort of overcoming the need for AT3. You're directly inactivating or blocking thrombin. Basically, what we saw was that when you used bivalirudin instead of heparin as your anticoagulation, that even when you support kids for 120 days, overall, once you get to steady state, the rate of bivalirudin that we were using was pretty steady for, months, and it had a more steady level of PTT associated with it. So it's thought to be a better anticoagulant. We actually did see in a small number of patients with early adoption much better outcomes, fewer strokes. So instead of waiting for a multi-center registry, given the power of the Action Network with really, powerhouses in the field of pediatric VAD, a few centers in early 2018 sort of implemented a change based on a few favorable outcomes and good science to switch from heparin to bivalirudin for using anticoagulation for these patients. And very quickly, the rate of strokes dropped from 30% to honestly less than 10% sometimes. And the results were so favorable. And again, this is quality improvement, real time work, that overall, just at the end of that same year, Action sort of implemented a broad range of QI initiatives across their centers to use bivalirudin primarily as the early postoperative anticoagulant of choice. And for those of you who've been in our CICU, we now use that primarily and exclusively for all of our VAD patients. And there's moves across the country to start using this exclusively for ECMO as well. So that is a huge change in a short time period, and it's pretty awesome. And this is one of our patients who's been on the floor now for almost a year with a Berlin pump, and knock on wood, she has not had any concerns for any neurologic outcomes, and she's doing really well, which is pretty awesome. Now let's shift gears a little bit to talk about options for older patients who have severe heart failure needing a VAD. And really the only pump out there right now for durable support is the Heartmate 3. And this is basically a figure from the major adult trial looking at the Heartmate 3 in adult patients with refractory heart failure. And what we found is that, over time, the Heartmate 3 and essentially, really good VADs have become so good that their survival at 2 years is equivalent to that of a heart transplant, without needing to take lifelong immunosuppression, which is pretty awesome. And so, let's go forward to how did we bring this to pediatrics? And the Action Network again had a huge role in doing that. And these are slides that my colleague Dr. Friedland Little shared with me that really, a lot of this data helped bring the Heartmate 3 to pediatrics quickly and with FDA approval. So it's basically all the centers collaborated to enter their patients who had Heartmate 3s in real time, and we looked at major complication rates, including stroke rate, bleeding rate, infection rate, mortality, and pump malfunction. Early on in our experience, these numbers were pretty low, like less than 1% for stroke, almost non-existent pump malfunction. And essentially using this data, and I think it was less than 50 patients at the time that this data was submitted to the FDA, but using data from many centers across the Action Network, the FDA approved the Heartmate 3 LVAD for pediatric use. So it's really the only pump out there that's approved for use in older patients with heart failure. And that's a huge deal because if you think about the time that would have been required to do this at a single center to recruit 50 patients, it would have been many, many, many years. And the reason this is important is once something is FDA approved, the company can then actually create pediatric specific, patient education tools. They can actually come to the center and provide training, which previously was just relied on a lot of the clinicians at the site to do because, it's completely off-label use. So this is a huge, huge win. And I hope it's a trend toward, working together as a community for our most vulnerable patients to kind of make things happen and hopefully then, create some sort of not liability, but partnership with a lot of these companies that have a lot of resources to help our patients. And I want to shift gears again a little bit to talk about the power of real world data. So again, there's a lot of money out there, and a lot of that is being focused into in the adult world. But I think we can sort of harness our power to use that as well. So if you look at the total healthcare TAM, which is a total addressable market, it's growing over time and specifically in the realms of data and analytics, and it's projected to grow considerably over the next 5 years, and a lot of that growth is going to be focused on payment integrity, so making sure that you have basically correct diagnoses, that you're using the state of the art. And there's a lot of focus on quality and network management. Um, and and a lot of people think that the way that we'll be able to do this successfully is to use artificial intelligence in healthcare. And the hope is that using data and AI, we can start to detect early when patients are getting sicker. And I'm sure you've heard a lot about people using the Apple Watch to detect AFib, or sometimes even to detect thyroid disorders based on heart rate alone, to kind of help us monitor our patients. We talked a little bit about using data to improve decision making and overall to improve patient experience and even sometimes inform end of life care. So I want to talk a little bit about how we're trying to use wearable technology, data, and real world data and AI at Seattle Children's to help take care of our patients. If anybody knows me, I like acronyms. So it's called a HERO trial, and we're basically using heart rate changes to predict heart transplant rejection. So, over 6 million adults in the United States have heart failure. Um, and there are about 3,500 heart transplants that are performed in the United States, and about 500 of those occur in children. As of right now, there's about, a 10 to 15 year survival rate for a heart once it's implanted in a patient. So if you're thinking about implanting a heart in a 5-year-old, it only gets them to age 15 or 20. So there's a lot of room for improvement. And people think that some of that may have to do with, children, especially teenagers, not reliably taking their medications, or just late detection of rejection, because it can be sort of subacute. It can mimic a lot of common pediatric infections like GI illnesses and respiratory illnesses. And our current methods of keeping, track of our patients once they're out there in the world is sometimes really cumbersome. And we rely on them to take medications 2 to 3 times a day. Our nurses have to send out lab slips. The patients then have to go and get labs. We have to look at the labs. We have to titrate their immunosuppression. We often ask, parents to check heart rates and blood pressures a few times a day. And if you can imagine a layperson doing that, there's a lot of error that can potentially occur. So there's a lot of patients out there, a lot of data, and definitely room for improvement in terms of survival. And when you think about rejection, which essentially means your body is identifying a heart transplant as something that's foreign, it occurs relatively commonly in the first year, both in pediatrics and in the adult world. Data suggests that rejection occurs in up to 20 to 40% of patients in the first year post transplant. It's a huge factor in morbidity and mortality after transplant. As I mentioned, that presentation can be quite variable, and sometimes kids can present really sick when there's not much left that we can do. So how do we detect them early? Well, our current practice is not ideal, but it's the best that we have. And it's essentially to bring them into the clinic every, twice a week in the beginning, once every couple weeks as they go on further. But once they get to after 1 year post transplant, we really only see them in the clinic once every 3 to 4 months. So you can imagine there's a whole period of time where they're just out there in the world, and we won't know they're sick unless they tell us or unless their labs are abnormal. And what we do, and it really depends center to center, but periodically. So here we do it about 3 months post transplant, and then annually we take them to the cath lab. We place a catheter in their groin or their neck, and we advance it to the heart, and we essentially take a sample of their RV endocardium. We look at it under a microscope, and we say yes or no rejection. So you can imagine, most of the time these patients are coming in without any symptoms. So our yield with these biopsies is relatively low. There is some work, especially in the adult world, to start to use more sensitive measures like drawing blood and looking for donor-derived DNA to detect rejection early. But that technology is still pretty early, and it's better at ruling out rejection and not that awesome yet at identifying rejection. So how do we improve that? Well, there's a lot of potential again for using wearable technology for smart monitoring. Um, it provides a lot of data depending on the device that you're using. You can potentially get heart rate, you can get heart rate variability, oxygen saturation, VO2 max, some sort of arrhythmia detection. It's pretty powerful and relatively highly reliable, and it can provide real-time data for patients. We're learning as clinicians how to use that data and incorporate it reliably into our practice, but there's a lot of potential. There are a lot of companies out there that are figuring out the best way to do that. What we're trying to do here at Seattle Children's is to partner with Amazon Web Services to figure out how to use wearable technology to detect heart transplant rejection early. So again, it occurs in 20 to 40% of patients in the first year post-transplant, and it can have pretty fatal consequences. So to start, we're just doing a phase 1 feasibility trial. The devices will be donated by Amazon, and essentially the data will be extracted continuously to the cloud. But for the phase 1 trial, we'll just be demonstrating that patients can wear the device for more than 70% of the time. That sounds simple, but again, these devices need to be charged every night. These are kids who have a lot going on. They have a lot of medications that they need to take. They have school, families are busy. So first we have to demonstrate that they can reliably wear the device and that we can reliably have the data uploaded to the cloud. So we'll be including pediatric patients more than 5 years old who have undergone heart transplantation in the last year. We'll be looking at their heart rate variability, number of steps per day, and some data on body fat that will just be collected passively while we try to figure out whether this is actually feasible. And in the meantime, we'll have funding for a study coordinator to call these families every day to really identify whether there were any barriers to wearing the device. Did they have any symptoms? Did they exercise? And what time did they go to sleep? The reason that's important is if you can imagine, um, there is some fluctuation in the heart rate that occurs with exercise, even when you have a heart transplant and the nervous innervation to the heart is severed. So really the baseline heart rate that we care about is at rest, and the easiest way to identify that is by figuring out when kids go to sleep. And then once we figure that out, we hope to kind of then follow these patients, a larger group of patients over time, to really understand what does heart rate variability mean in a transplanted heart. There's some data in the adult heart failure population that indicates that decreased heart rate variability is an early marker of poor outcomes in patients with heart failure, but there's no data out there in pediatrics or in adults about what that means in a transplanted heart. And again, no more nervous innervation to modulate that sinus rate. So that'd be really interesting. And again, clinically, we use a resting heart rate that patients and their parents give us as a surrogate in our head to think about risk factors for rejection, but we don't really have real-time data. We don't know at what point that heart rate changes and whether that could be used as an early marker of rejection. So we're going to be collecting that data and then associating it with our clinical findings and the results of our biopsies. And finally, using the powerhouse of Amazon that we have here so close by, can we use their technology and their engineering brains to figure out how to use machine learning to just auto detect heart rate changes that are meaningful and that might indicate that something is wrong. So that's really exciting. So we talked about a lot of things, right? We talked about major QI studies. There's a lot of them that we use in Seattle Children's, and we just talked about the ones in pediatric cardiology. We talked about partnering across institutions to pool data to make real-time changes. We're talking about FDA approval, which is sometimes so hard to get. And we talked about using data that we have every day to potentially inform our practice. So what are some things that are out there that, people can use outside of cardiology? So I wanted to touch on that really briefly. So this is really cool. I learned about this just, during research for this talk, but there's the Gabriella Miller Kids First, which is basically an NIH funded program that's collecting data prospectively on children with either cancer or some sort of structural anatomic defect. And all of these kids have undergone genetic testing. And anybody can submit a proposal to get this data. So that's a huge amount of data in lots of patients with genetic data available as well. And as everybody knows, that's sort of the future of healthcare. And so I'd really encourage anybody who's interested in these disease populations to take a look at this. The website's here. So I would really encourage that. That's an easy way that could potentially impact lots of different specialties. I think a couple of weeks ago, there was a grand rounds on basically the engineering innovation and health program at UW. So it essentially partners clinicians with engineering students at the UW to do a few things, and that's to identify, important pain points and avenues for innovation within pediatrics. And then teams work together to think about creating a prototype to solve those problems in an innovative and cost-effective way. And their goal is to get patents, right? They want to produce things and to use that for either future funding and research, or at least to publish something to get, the community talking about ways to do this. So I won't talk too much about it since there was already a grand rounds, but this is really cool. They have rolling submissions. And I think to be considered for the next year, the submissions have to be in by August. And then finally, I've found that tech companies are really hungry to partner with us, right? And Amazon Web Services is what we use to host a lot of our cloud data with Epic. And they are really interested in working with clinicians here to solve a lot of important questions that they can then, use with their technology to market and strengthen their healthcare arm. Just this last year, we partnered in the AWS hackathon for the Hero trial. And essentially what the hackathon does is it takes a lot of Amazon people, it takes our own Seattle Children's IT people and a group of clinicians, and it helps kind of identify projects that are ripe for engineering and health tech innovation, and getting minds together to think about the best ways to move those forward. So it's pretty powerful. I imagine it'll happen again next year, but something to look out for. They're doing hackathons across all industries, including fire departments, and there are lots of other, large and small healthcare technologies in the Seattle area that I'd really encourage you to start networking with to harness our combined powers, right? We know what's important, and they have the technology, and working together, we can get things to happen a lot more quickly. And since we have a couple of minutes, I just wanted to talk about, ways that, our own team here in the Seattle Children's Heart Failure Transplant team has been creative about driving innovation with medicines. And one way is by focusing on patients with heart failure. So, adults have a lot of data. This is an image from the newly released ACC guidelines for treating heart failure in adults. And it's basically like, okay, if you're an adult with heart failure, these are all the things that you do. They have, stepwise additions. They have doses that are readily available out there. Unfortunately, in pediatrics, a lot of these medications, either there's no data or a lot of the data have shown negative results in pediatrics, but it's all that we have. And historically, what we've done is kind of just use these medications off label to help our patients as best that we can. And really here at Seattle Children's, we've been kind of forerunners in using a lot of newer adult heart failure drugs to support our patients. And I just wanted to talk about them really quickly. So one of those is sacubitril valsartan, or Entresto. Without going into too many details, it's basically using two drugs. So sacubitril, which is an neprilysin inhibitor that blocks or impacts the BNP pathway within heart failure, and then valsartan, which is an ARB that basically impacts your renin, angiotensin, aldosterone system. So it's working together, and essentially has been shown in adult trials to compare to what was commonly used, which is an ACE inhibitor, really decrease overall cardiovascular death or heart failure hospitalizations in the adult world. And As part of that, what they found was that the BNP, which is a marker of atrial stretch and is often used as a surrogate for severity of heart failure, decreased significantly in patients who are on Entresto compared to those on enalapril. So this company actually tried to do a pretty extensive study in pediatrics as well. It's called the Panorama Heart Failure Study. But again, we talked about it in the beginning. Pediatric trials are slow to enroll; they're kind of slow to complete, and they had to continuously expand their criteria, extend the inclusion to many countries across the world in order to get enough pediatric data. And we're still working on completing the results. But essentially, again, because the company did this trial in pediatrics and collected data prospectively, they did go ahead and do an interim analysis at 12 weeks. And what they found was that compared to enalapril, patients who were on Entresto had a lower BNP, and the effect size of that change in BNP was higher than what was seen in the adult study. And based on that data alone, Entresto was approved for pediatric use. So it's really the only heart failure medication approved for pediatrics based on what some people will say is really minimal data, but there is a huge, huge impetus out there to get pediatric specific drugs studied and approved. And I think that should be a motivator for all of us. And here in Seattle, I borrowed this from one of our pharmacists. We've been really, I guess, like forerunners of implementing this medication in our pediatric heart failure populations, just based on the significant improvement in the adult population. So we're not waiting until the trial results get published, who knows when. And our pharmacists have been really awesome about creating really nice dosing algorithms that people can use easily just by looking on Lexicomp or Epic, with clear titration measures and clear safety measures. The same is true for isosorbide dinitrate and hydralazine, which you may hear referred to as Bidil. It's been shown in adult patients with heart failure, primarily Black patients with renal disease, to really decrease the incidence of death, time to first heart failure and hospitalization, and change quality of life. And really the only pediatric study using this drug was published by our group here, which basically showed, again, a decrease in BNP, which is used as a surrogate for heart failure severity, and small, tiny increase in your fractional shortening, or marker of your heart's ability to contract effectively. So that's really cool. The same is true for this really, really novel drug, SGLT2 inhibitor, which was studied in the primary one that was published initially was DAPA-Gliflozin, and it was the DAPA-HF study. Another reason this drug is really cool is it was actually designed for use in diabetes. And then in following patients with diabetes who long-term, they found that they actually had improved cardiac outcomes, so decreased morbidity and decreased cardiovascular mortality. And now this drug is, completely marketed toward patients with heart failure, both with preserved and reduced ejection fraction. So another important example of the power of data and the power of collecting and analyzing data and using that to inform clinical practice. And what it showed, again, was that, compared to placebo, dapagliflozin, that adult patients had a decreased risk of heart failure, morbidity and mortality, and hospitalizations over time. And again, our group is the only pediatric publication of the use of this medication out there. It's not a huge number of patients, basically 18 patients using DAPA matched with 18 controls, but it's getting data out there and early, and a number of institutions have reached out to us since then to kind of talk about how we think about dosing, what patients we use it in, how we think about overcoming insurance obstacles. In this early data, there was not a significant difference in overall outcomes like ejection fraction, morbidity, and mortality. Again, it's really small numbers, but what we did find is that it's a pretty neutral drug, even in pediatrics, meaning doesn't really impact blood pressure, which is really important, especially for little kids who oftentimes can't tolerate medications like ACE inhibitors, ARBs, or Entresto, um, and that it did not really have a significant impact on renal function. And again, our pharmacists have been really awesome at helping us figure out doses, how to surveil these patients, and how to think about safety. Um, so I hope that was helpful, and I'm happy to take any questions at this time.
Thank you. Super helpful and interesting. We already do have a question. I'll encourage all of our participants to either unmute if you want, turn your camera on to ask your question, or go ahead and type it in the chat box like we've been doing. And Dr. Tamura already has two questions for you and a comment. Super interesting. Thanks for a great talk. With regard to the HERO trial, two questions. Could you use the motion data on the device to accurately define exercise? And could you or did you give each participant two devices so one could always be charging?
That's a great question. So I think the second one is a little bit easier to answer. So one, I think, when we think about these devices, they're not super expensive compared to some of the other devices that we use, but they're certainly not inexpensive. So probably somewhere around the range of like $50 to a couple $100 depending on the device that you're using. So in terms of getting the device out there to as many patients as possible, and to really think about using it, long term as a surveillance measure. We didn't think about using two devices, but that definitely would be the ideal way to do it. And then in terms of using motion data, that's a great question. We are tracking steps as a surrogate of motion. There's some really interesting data that was done with a collaboration with AWS and pediatric oncology and looking at motion. And so this was still while kids were in the hospital, but for kids who had undergone chemotherapy, they had them wear I think it was an Apple Watch, and they detected their steps per day while they were still in the hospital. And they found a correlation between increased steps and a decreased incidence of readmissions for recurrent, chemotherapy related problems and cancer recurrence. So it's something that would certainly be powerful to use in pediatric heart failure and pediatric transplant, and something that we'll definitely be using. I'm really interested in using the VO2 max in all of our patients. It's not validated, and it's hard to use in patients who have hypoxemia at baseline, but I think it would be great to get that information if we're able to get that number of Apple Watches, but they're kind of expensive.
That's a great idea. Thank you. And I'll wait for anyone else to either unmute or type your question. We have about 8 minutes left. Quiet group today. That was a really, really interesting talk. Thank you so much. And the technology aspect is especially exciting. So very, very cool.
Thank you. I think in thinking about the pace of innovation in healthcare, and especially in pediatric healthcare, I think we have a lot of catching up to do compared to the business world and other industries. And I think by partnering early with a lot of these healthcare companies and thinking about ways to store data safely and to analyze it in a smart way, I think we can hopefully make up for lost time. Because I think what people are learning is that there's data, and then there's what do you do with data, right? So a lot of the limitations of AI so far are that you have all this data, and AI, when you're at least making algorithms, works really well in a controlled setting, but then when you put it out into the general population, those results don't always hold true. So hopefully by working with experts in this field and and working together, we can try to do this in the best way possible.
That's awesome, really inspiring. And we are set up well with the UW. And you're right, just a couple weeks ago, we had our speaker from there talking about the innovation that they're doing. So partnering with them is a great idea too. We're really lucky to be here in Seattle.
We are really lucky. Hopefully the sun will come out as this
I think
weekend,
it
and then we'll be really lucky.
did. Maybe that's why there's no questions. We'll
Yeah.
let everybody go. I'll wait like 30 more seconds. And if nobody's going to talk or type, we can let everybody go outside because I think it did become summer just now.
Oh, awesome.
I can't guarantee that because I'm in my basement, but I'm pretty sure. I'm pretty sure. All right. Well, um, thank you so much for being here and for all the work that you're doing, and to all our Grand Rounds participants for being here with us on WebEx. We really appreciate you. Just another reminder from me, we'll be back in Wright Auditorium if you'd like to join us in person on July 14th. And until then, we'll continue on the WebEx and after then too.